So the management of ischemic stroke consists of three main approaches or parts. We have the primary prevention, we have the acute phase management, and we have the secondary prevention. Let's start with primary prevention. In primary prevention, we will try to reduce all risk factors that are high in our patient in order to reduce the risk of stroke. For example, we can control blood pressure, control blood sugar, control obesity by weight loss, increase physical activity, and etc. We have to educate patients about the warning signs that we have mentioned previously, the warning signs of the stroke, and to instruct the patient how to seek emergency care. Also, we have to treat the arterial fibrillation because we still have almost 70% of cases are inappropriately treated. So we have to focus on arterial fibrillation, patient education, and risk factor reduction. So for primary prevention and to start anticoagulation for any patient with arterial fibrillation, we will use CHADS VASC score. CHADS VASC score contains multiple points or multiple risk factors or multiple categories. We have two parts. Some of these categories will have 1 point for each, and some of them will have 2 points for each. For example, we will give 1 point in CHADS VASC score for each of the following: congestive heart failure, hypertension, age between 65 and 74, diabetes, vascular disease, and female sex. We will give 2 points for each of the following: if the patient has previous stroke, or the patient has transient ischemic attack, or the patient is 75 years or older. After calculating the CHADS VASC score, we have 3 categories. If the patient is younger than 65 with lone atrial fibrillation, irrespective of sex, we will give 0 in males, 1 in female. So if we got 0 risk factors in male, 1 risk factor in female, we will give no therapy. So the cut point for female is 1 and male is 0 to not give any therapy. If the CHADS VASC score is more than 1 in males or more than 2 in females, we will consider treatment with aspirin or oral anticoagulant. If the score is 2 and more, either in female or in male, we will give oral anticoagulant or dual antiplatelet therapy in patients who are not candidates for direct oral anticoagulants or warfarin. The second part is the treatment of acute event. So the patient, regardless of risk reduction, the patient developed stroke and arrived to the emergency department, how we will manage the actual stroke. So after CT scan, after defining and giving the definite diagnosis that this is an ischemic stroke, we will start with thrombolysis. Our first line choice is Alteplase. We will give 0.9 mg per kg, maximum of 90 mg within 4.5 hours of symptom onset. 10% of this total dose will be given as intravenous bolus, followed by the remaining 90% of this medication as 60-minute intravenous infusion. We have to be careful because any antiplatelet agent, aspirin or clopidogrel, should be held for 24 hours after tissue plasminogen activator administration. So once the patient arrives, we will hold aspirin, we will give thrombolysis, Alteplase, then within 24 hours we can reinitiate aspirin or clopidogrel, whatever the patient has.